people are here. Vision and mission statement are posted. Always want to review why we're here. The first talk, or the first item here, is discussion of stroke-specific continuing education requirements for EMS personnel. And so, HT, you want to talk about that, or you want me to talk about that? Okay, so this has been an ongoing item for the stroke committee with the discussion of wanting some stroke-specific continuing education. Currently, there is no stroke-specific or neurological-specific requirement for continuing education for EMS personnel, either state or national registry. It falls under medical. There was a good presentation at the stroke committee yesterday with some new recommendations going to thrombectomy even after thrombolytics. So I think there's going to be some stuff changing from the hospital standpoint. But it was pretty disturbing that all of the data that's been presented shows that we're still missing, EMS is still missing about 40% of strokes. We're not recognizing them. And I think as the interventions change, obviously appropriate destination is very important. So it's been brought up, and the discussions today were in education, and I don't know if the EMS, did they talk about it, HC? AMS did not talk about it. The education committee had some concerns about making specific carve-outs in the medical section. There was a feeling that every specialty or special interest would want specific continuing education. My concern and argument with that is the fact that stroke is the fourth leading cause of death and in huge morbidity, mortality associated with it. So I'm shocked at something that is that frequent and that significant does not have specific requirements for continuing education. So the one side of the argument is nobody should tell me and my service what CE we need. On the other side is that an EMT or a paramedic could do their entire career without having any stroke continuing medical education. So discussions.
I think my point at the last committee was that, National Registry has a fairly strict criteria that we all kind of have to preach to. And so every time we go through it, we have to do hot and cold emergencies. Like, really? We don't get that many hot and cold emergencies in East Texas. But we get a hell of a lot of strokes. So why can't we teach to the things we really are treating? So maybe we should refocus the whole debate by changing what National Registry requires of everybody. Why should they be able to do a 1% call topic and skip off, a 50% call topic in terms of the volume we have?
So National Registry does have mandatories, and I'm just reading the paramedic mandatory. So there's 3 hours of medical emergencies that are mandated criteria from National Registry. Those 3 hours are allergic reactions, possible overdoses, and drownings. Now, there are flexible core content or medical emergencies that 5 additional hours, which you could have in stroke specific. And I don't know, Bill, I don't know how the process changes for National Registry. I don't know. I'm not on their board, so I don't know how those.
Is David Purse?
Dr. Beeson, I can help you a little bit on that.
Okay.
I can tell you that the registry is looking at their whole Con Ed requirements right now, and they're going to roll it out later this year. It's going to be a 3-step process. There's going to be some national requirements, there's going to be some state requirements, and then there's going to be a process where the practitioner can go in and do a self-assessment online. They get the results back, which tells them where they need to do some additional education. I have not been to a formal presentation. I know Brett Hart was, but we'll be hearing more about this later this year, and I think that will help focus some of this discussion. The only thing I would add to this discussion, I think it has to be a kind of a 3-way triangle. We need to, whatever we do, we need to make sure we include the unit medical directors, we need to include the practitioner, and we need to include the hospitals, so that if we do a great job and we take them to the wrong hospital, or we take them to a hospital where they're not recognized, then we haven't done anything beneficial. So I think this conversation is a great conversation in moving the issue forward, but I think we need to look at developing a whole program, not just say you got to sit down and do an hour course someplace. I'm not sure that's the answer to the whole thing.
I think that the question of should we do something, you've answered it in your introduction. It's the fourth leading cause of death, and you tell us that we're missing 40% of strokes statewide. I think we owe it to the people of Texas to do something, a comprehensive program, perhaps more than just an hour of training, but clearly this is something that needs to be addressed.
And just not to correct you, but it was the 40% was on California only because there's no data in Texas on this. We're going to look at that. I said this morning to the Education Committee, I had the opportunity right before coming to Texas to work on a pilot program, Lehigh Valley Trauma Center, and up there in the Allentown area, where they took that approach, hospitals, EMS, on developing a good plan, a whole plan for dealing with stroke patients. And I emailed back to them yesterday and said, any research, any documentation you have on us to show how well it's going. And they developed a trauma alert. It's a stroke alert, and hospitals are reacting to it with the information because the paramedics and the EMTs have been better trained in the field also to recognize a stroke. So I don't know if that's been successful or not, but I'll have the information soon on that.
Joe, one of the things that might be helpful, particularly for new medical directors, would be to occasionally have this committee or the state send out, these are our QI topics for the year. We'd like for all of you guys to be looking at these 3 things. We're not going to burden you down with 17 things, but at least for us, would you pay attention for the first, for this year? Let's look at strokes and tell us, did you send them to the right hospital? Did they get better? Did they get worse? What are your problems? Just look at the whole topic. Maybe give some suggested questions, but a little guidance, particularly for the new medical directors. They don't know what to necessarily ask, but if it's something we're interested in, why not ask them to do that?
Yeah, so one of the examples you used about drowning and allergic reactions and all that being mandatory came from just this kind of discussion, because somebody got up and said, drownings are a cause of 40% of whatever. I was like, oh, we need to pick that. Let's make that one of the discussions. So we're just repeating kind of, if you will, the same mistake by picking a disease process and giving it mandatory number of hours. Because 20 years from now, people are going to go, why do you spend so much time on stroke? Yeah. Ever since they came up with that other medicine, that's not a problem. So let's not repeat let's not repeat the same mistake by making something mandatory certain number of hours. Let's emphasize a training as it needs to be emphasized. That's kind of what National
Registry has been doing with snake bites all this time. Come on.
Yeah.
How many stings and other things can we talk about?
So I'm opposed to actually picking a number of hours, making it mandatory, because we're just recreating the same system. We're criticizing of what we're doing instead of what we should be doing. The other thing is to say that EMS miss 40% of strokes. Guess what? ER docs probably miss 39%. Strokes are hard, right? Strokes are difficult. They don't show up with a EKG. They don't show up with a bullet wound or a stab wound. Strokes are hard. So,
And you don't have time to do the full NIH prior to getting there.
Right. So it's should be much more of a systems approach and something that's going to be more flexible than saying we need to pick 3 hours of stroke education. That's my personal bias.
So do we not think that as mandatory trauma CEs, and now as physicians, if you work in a trauma center, you're mandatory trauma, do we not use the same analogy of that? I mean, has the mandatory CE for trauma not improved the outcome of trauma systems and trauma patients?
I don't think anybody can prove that at all. And it's trauma related, by the way. It's not trauma. So anything that's airway is related to trauma, and it counts.
How long it took us to find out about epi.
Yes.
No, you're right. Okay.
Yeah. So just because you can measure it, and just because there's some outcome doesn't mean they're directly related. But I just don't think we need to, because somebody else said we're going to have everybody's going to line up and say, well, hey, this is a problem. You need to have this many mandatory hours too, and it's going to push something else out of the way.
It's a battle we fought for years.
Correct.
It's on the GETAC agenda for tomorrow. Do we have any recommendations or any discussions or anything want to come from this committee to GETAC?
I would recommend that we at least apply some influence to the powers that be at National Registry to see if we can supplant some of the silliness with something important like stroke.
So that'll be a personal thing we can all work on, but nothing to recommend or advise the council.
We can do it through the people we know on National Registry. I mean, David Purse can help represent us from Texas. I don't know if there's anybody else from Texas on it.
So the director, Trey, is from Texas. And
Oh,
I'll
Trey
actually
is-
see him this Saturday, having dinner with him. So what?
Well, there you go. Joe can do it.
I think, Dr. Greenberg, or Dr. Beeson, if we're going to have a recommendation, it seems to me is that we keep working with the Education Committee for a system solution. And that's what I heard from the Education Committee. Let's look at the whole system and how do we solve it system-wide. Because you can also argue that it should start with the 911 center on pre-arrival instruction. So there's a whole gamut here, not just one little piece.
Yeah, and this is somewhat similar to when we've had people come up and ask for specific medications to be carried on the ambulance.
Oh, yeah.
And we've been opposed to that. But
And they're in D.C., by the way, right now.
I know, yeah, I know. But we're opposed to that, but we are very much in favor of addressing the problem of, individual medications. Nobody's certainly opposed to more stroke education. I think we're opposed to mandating it. And why 3 hours?
There was no number. I think it was just some specific stroke neurological related.
Right.
See, Taylor. Sorry, Dr. Ratcliffe. Sorry.
No, Taylor's good, or my street name, T-Rat.
Okay,
That
T-Rat.
works.
T-Rat.
It's his
T-Rat.
ED name, too.
That's right. I do a little rap singing as well. No, and that was, I didn't, maybe I was coming across as being a voice of dissent this morning when we discussed it, and that wasn't my intention. I was just scared that in 5 years we were going to be sitting there looking through 20 different people who wanted, lizard bite education or what. I won't get that crazy, and I agree we could target the top 5 diagnoses or whatever, and that was what the Education Committee said is, hey, look, we want to push out meaningful literature and education every year. And so I think it will require the medical directors group to come back. And the idea that we came up with was maybe almost sort of a cohesive plan to mimic, almost like, I dare say it, the LLSA articles or something. I know that's painful, but could we do for the state for a given year, could we all put our heads together and say, hey, look, this was the best research that came out that's applicable to us for 2015. And instead of mandating a number of hours or something like that, satisfying that stroke education piece by saying, these are the key stroke articles that we want everybody to pay attention to and read, and then offer them some kind of, surely we could offer them CE or some positive benefit for that. But
Okay.
I would see us working together on that.
Dr. Andrew Barretto at UT Houston just came out with a study, 40 patients of people who awoke, they were asleep and they woke with a stroke. And they went ahead and gave TPA. It's unknown time, and they had an excellent, at 90 days, half the patients were fully recovered from the stroke. That's just 40 patients, but that may be changing the way we do things. Right now, my medics all know, well, if you don't know when it started, you can't call it a code stroke.
Sure.
In this case, maybe we can. It may change the way we do things.
Linda Dickerson, GETAC public member. I am very much for stroke education. I don't care how you do it. If you go through the racks, you mandate it. It's important. Heart attacks, the legislature, we have one committee just for strokes that we can't eliminate. That committee's here forever. And strokes are important, not only for my age, and I'm old, I'm very old, but for young people as well. It goes across. So I don't care if it's a basic that comes to my house or it's a paramedic. I'm going to expect them to kind of get, I know strokes are hard to diagnose, but if they can't lift their hands above their head, and if they can't do a straight smile, and they can't repeat a sentence, then odds are you might be thinking about strokes. And that's what they put out on the airways on TV for the public to know. I want y'all to be smarter than me, Miss Public, okay? So I don't care how you go about it, but I know if it's mandated, it all of a sudden becomes valuable, okay? Because you can check it off. So y'all come up with it, education comes up with it, strokes. But the medical directors, y'all are so important. It's like the racks. Y'all all have to work together. So for the public view, y'all just find some way to make it work so every basic to paramedic can take care of me when I call 911.
HT, you moved up.
HT filling in with the stroke committee. A couple things I want to say. Our intent is not to take away from any programs the services have established, where the medical directors are taking care of business on a local level of things that are important for that. If it's in our area, if you drown, it's going to be from dirt, not water, because we don't have any water. But other places, you got water, and that's something you better address. It's going to happen. And our intent was not to take away from that, but to support that. And I don't think the state's intended to make anything mandatory or take away from what's already going on, because everybody knows locally what they really need, and that's the way it should be.
We would assume that people know that, but once again, the people that come to these meetings that are active are probably not the problem, but it's the rest of the state. I mean, that's the issues we talked about.
And I think in view of the study from the Netherlands and some of the other places, the idea that seems to be picking up a lot of steam nationwide is for stroke care, that EMS is notified, basically can recognize stroke, begin whatever treatment modalities that their local people are comfortable with, to get them to TPA, CT or CTA, and then get them to a facility that can go in and suck the clot out. Okay. If that's the same place, great. If it's not, like for us, it's not going to be the same place. Our hospital has a CT, we have TPA. We use the CT, but not TPA. We've got to get kind of be planning for that, because it's going to happen. And EMS is the ones that's going to get kind of, that's going to be our job, is to start this cog and rolling. And if we don't do a good job, it's not going to work. And so I think that's the reason that we simply want to make available, and so that we can kind of all get on the same page, whether you're a little podunk place like mine or Houston or Dallas or wherever. We're all talking about stroke. We recognize what's going on, and that's our intent. Is not to, we just want to do the job better, and we think that would help. One of the surveys, and you guys can check this on American Heart Association website, when they asked medics, what do you need? And they said, we need stroke education. We really don't feel good with this, but we don't have it. And I think y'all witnessed that this morning. Nobody requires it. I mean, you do the best you can. And if you have a medical director that, feels like, hey, we need to do that specifically, that's awesome, but that doesn't happen very, very much. I mean, I've been doing this for 40 years. I've never had any training on stroke. If I didn't get it in my classroom, I didn't get it. My CEs don't require it, okay? And we think it would help to refresh us. And you're talking about National Registry. I want to say, I'm not nationally registered, and a lot of folks are not. We don't go to their page. We worry about Texas requirements, and that's what we're concerned about, is that would help get our ECAs, our first responders, our EMT basics, our intermediates, everybody on the same page. If we go through the Texas requirement certification thing, it doesn't add extra. It's just saying, hey, at least look at some amount of time with this and get on the same page.
So maybe, what if, as an EMS director, you got a thing through the email from the State Department here, and it had, this is a updated instructional course on stroke. It's for your use. Feel free to use it. Your medical director probably needs to see it.
Sure.
And
Absolutely.
tie into it. And it's just not mandated, but it's pretty obvious that it's something that we think is important because it comes from dishes. And so, what if you did it that way rather than putting your hands in the fire?
Honestly, I think some of your smaller services that are volunteer and whatnot you pretty much have to tell them what you got to do. I mean, they get really upset when you come inspect their ambulances. Because you're not supposed to be here, get away. We're doing fine. And that's one of the concerns that we had, is that if we had something that said, hey, when you recert, you're going to get an hour of stroke. That's kind of what we wanted to do, was to pull everybody together just for a few minutes on the same page and try to go forward from there.
Maybe before you get your car registered.
Yeah. Well, I mean, I guess it's kind of the same way. Before you get your license registered with the state, you have to pick up your CEs, and one of them's going to be stroke. That'd be, we're not designating an amount of time. I mean, that's why we're talking to you guys. What do you think? We're riding on your license, guys. That's got to make you nervous. Okay, it really does. It's got to make you nervous
Every day.
Yes, sir.
He ain't got anybody riding with
that
him. Don't listen to
phone
him.
at 3 o'clock in the morning is
Taylor,
not
where
what
you
you want to hear when it comes up Medic 4. We want you guys to feel comfortable with this and support us and give us what we need. Okay, it's kind of like a talk to the education committee. You guys are the teachers. I'm the student. We're not getting enough of this. Help me out here. What can we do? How can we do this? And I never envisioned in my whole life that this would be such an emotional thing. All we want to do is just get on the same page and do a better job. This is Texas. We're better than that. We deserve better than that, and we're capable of doing it. That's the thing. Our system is a little bit different than other states. You guys call the shots, and that's pretty awesome, because when you get involved, when I can call you at 3 in the morning and say, "Hey, Doc, I got this going on. I don't know. Give me some guidance." That's awesome. Okay. And so for that reason, we're asking you guys, what do y'all think? Okay. What?
Okay.
So,
Thank you.
thank y'all.
Anything else? I think it'll be discussed more tomorrow, I'm sure.
But they're going to ask, council's going to ask for a recommendation from us. What's our recommendation going to be? We're opposed to a set requirement. We're in favor of the concept, but opposed to a set requirement of a number of hours.
Well, I think you and I see differently on this, so I think it's up to. That's why we're all
Yeah.
sitting here, because
Yeah, no.
I think this stroke's an important thing, and the fact that there's no mandatory CE is pretty scary.
When is a decision supposed to be made from the NREMT board regarding changes and recommendations?
So it's in pilot now. It'll start. There's a few, I know, organizations throughout the country that'll be starting here within the next few months, but this is only for paramedic right now. So the change in the continuing education or the recertification process, more of a self-assessment, will be later this year, but it will only be for paramedic.
So what is the resources and likelihood that the state could do like an annual requirement for some kind of education that would change? Because again, it's the same thing. 2 hours of stroke education every 2 years, every 2 years, every 2 years, and they're going to end up doing the same thing.
Well, Texas is on a
So-
4-year cycle, but yeah.
Right, but I mean, you know what I'm saying.
No,
So
I agree.
it's- you have to change the rule.
Which
So,
we're getting ready to
which
do
what
anyhow.
we're looking
We're
at.
still, it's a year. Make it-
So
then-
maybe now, at this point, we go ahead and send out as much information as we can to all the services and their medical directors and say, here's a PowerPoint. Please use it. And at this point, it's voluntary, and then maybe next year, as we get the new rules, it becomes,
And I think
now
that's
you
what
got
the
it.
education committee's looking at. I mean, they're looking at developing a program. And
Right.
they're going to go, this topic's back on their agenda for next year, next
Right.
month, or May.
Right, but developing a program or even doing a track at Texas EMS doesn't get everybody.
Yep, for
No.
sure.
Doesn't.
So, how do you reach out to everybody without making it so prescriptive that everybody gets taught about something they never do?
Once again, all of the RACs have stroke. I mean, there's stroke committees, there's regional things going on with the RACs. The problem is that it's not mandatory, so a large percentage of the population will never do it.
but RACs are getting funded for doing some of these projects. They're getting money.
No, the continuing education is available. The education is available
It's out
online. I mean, there's tons of stroke education. The fact of the matter is, do we think that it's substantial enough that there should be some mandatory education pertaining to stroke or not?
And I think, if you're looking for a quicker solution, I think you could make the recommendation, this could make recommendation to GETAC that they send a letter to every medical director in Texas saying this is an issue that you need to be looking at and addressing and making a recommendation for some continuing education requirements. You as a doctor can do that right now. You have the authority to do that. You can do the letter first and then come back with a more permanent solution. We have time to decide, do we put it an hour or do we say just, we'll get to see what the registry has put in place. Look at the rules. Do we put an hour to it, or we just make it a topic?
So we've spent 30 minutes on this. Is there any recommendation, anything from this board, or somebody make a motion that goes forth to GTAC for tomorrow?
So, yeah, I mean, yeah, that's what they're looking, that's what council's
Yes.
looking for.
Yep.
So absolutely.
Ultimately, I would recommend putting an hour or two, whatever we decide, but for right now, I think we support the other committees in developing, like Joe said, a systematic approach to treatment of stroke and recommending CE for everybody.
But I think the issue is
Not
the
mandatory, yes.
Yeah, the mandatory is the question.
So the motion from Dr. Moore is that we continue to assess the need and come up with potential plans, but at this point, it should not be a mandatory thing, particularly for
Until
stroke.
we know what to present.
Yeah, that's his motion.
Okay, so I'll second that.
Second.
To move the discussion.
Any discussion else about it? Call a vote. All those in favor? Aye. Any opposed? Okay. So, number two, the air medical group, and both the EMS committee discussed the background in this. Apparently, there are some air medical services somewhere in the state that are approaching specific industries or communities. I'm not sure the background. I don't know if anybody really knows where this is happening. It may just be anecdotal
Implication, it
stories.
was oil fields.
That was discussed. So in a sense, a helicopter service went to a drilling site and said, if somebody gets hurt, call us directly. There was concerns from the EMS service, or at least so, that they were not being notified of this emergency. And there's really nothing for this committee. I know that EMS and air medical are working on it. There's been some examples in San Antonio, the RACs and others, where they have had services sign agreements that they will notify EMS. But at this point, I don't think there's anything for this committee. Is there any questions about it I may answer?
Well, you can set rules for areas where there's some land mass, so a county has rules for who can respond and where, but, you know, I guess oil field guys are kind of used to being out in the ocean or something, and so there's no one to tell them who has to come. It has to be a helicopter, so they get used to that process. And,
Sure.
And it probably is just a slap on the wrist type thing rather than a new rule.
Okay.
Because they're in somebody's response area.
Yeah.
There's a 30 jurisdiction.
Okay. All right, Sam, the pediatric recognition.
So in November, I talked to you all about our pediatric EMS recognition program, and you had asked to present it a little more in detail here at this meeting. I'd be happy to put the PowerPoint in and go over it in detail page by page. However, I think that most, if not all of you, have looked at the document and have through emails to me and the rest of the committee, basically have approved it. There was just the one item on there that had to do with the EpiPen auto injectors. So I'm happy to put it in there, and we can go through it page by page if you like, or if you're okay with the email conversations that we had. And then I can also just update you on what our work group came up with too as the solution with the EpiPen auto injectors, if you'd like.
Yeah, I could have had a stroke between then and now, and I don't remember the discussion about the EpiPens.
So essentially, for the recommended medication list, what was listed on there for those services that it's within their scope of practice is the EpiPen auto injector. Due to the cost of those auto injectors, some of the services are not buying those, and y'all are teaching your EMTs how to draw that up. So I
Could
took
it
that.
just say or equivalent, EpiPen or equivalent?
Or equivalent, yes. So basically what our work group came up with is that basically the EpiPen auto injector is the preferred route. No medication errors. The alternative preferred method is to have a pre-filled syringe to avoid dosing errors, which would be 0.15 milligrams for less than a 25 kilogram patient and 0.3 milligrams for a greater than 25 kilogram patient. And then what is acceptable but not the preferred method is drawing up epi from a multi-dose vial. So that's what our work group came
What was the wording again? Because if somebody has a bad outcome and these kind of things just come back and they don't help us often. So what was the wording for the last one where you said it's,
Drawing up epinephrine from a multi-dose vial is acceptable but not preferred.
how about if you just put acceptable?
We could put acceptable, but it's not preferred.
Depends on if you're paying the bill.
The multi-dose,
Well,
is
the-
multi-dose the appropriate word too? Because I mean,
It's not, yeah,
it's not a multi-dose.
multi-dose
It's more of an
anyway.
ampule.
Yeah.
A multi-dose would be, I mean, you could draw up. I would say that a multi-dose draw is probably not the preferred because that's
Well,
100 milligrams of epinephrine.
There's a
Well, but you throw it away.
there's a newer technology. I can't imagine the pediatric group didn't wanted to use a UVQ, AUVIQ. It's just the same thing as an EpiPen, but it gives you verbal instructions. So for first responders that aren't used to it, it tells you put it on the thigh. Now hold it. Okay, keep holding it. Now retract. I mean,
Right, now,
it gives verbal instructions like the little birthday cards that sing to you.
So-
This is you pull the pin out and it says hold it. So why use a brand name, EpiPen? That's a company's profit, $100 a pen type thing. A UVQ costs the same amount and it gives verbal instructions. So we should be broader if we're going to write rules.
Well, it's not a rule, it's just a
write
recommendation.
policies or
Just a
whatever.
recommendation, it's not
Yeah.
a policy, just a recommendation. Yeah, we can use EpiPen, we can use UVQ, we can use whatever trademark brand name you'd like, or we can just put, I think most folks are used to know, and they know what the EpiPen auto-injector is. But I am familiar with that product, and as you said, it's cost about the same, which is great.
And
we
like
can-
for first responders, it's more comfortable for them.
Sure. No, and I agree. As far as the cost is concerned, I think that's what the issue was the cost involved of the EpiPens or that product or any other similar product. That's why the alternatives were thought of and created.
It would be easy to just replace the wording with epinephrine auto-injector, and it would
True.
take care of all
Yes.
of that.
Awesome.
And we can do that too. So,
And the multi-dose preferred.
the multi-dose, we will change that from multi-dose to ampule.
Okay.
Well, it's not even necessarily multi-dose. I mean, well, I guess it is because you don't give a milligram, so even a little 1 milligram, yeah.
All right, technicalities. Any
Yeah,
other
it's
questions?
not a multi-dose vial, though.
Okay.
All righty.
We might come back to you and then if we have time to see your
The,
data
okay.
assessment.
Okay, great. Thank you.
Can I make a motion that we support the EMS recognition program, volunteer recognition program that Sam has presented?
I second that.
Any questions, discussions? I have not read the whole thing.
I haven't,
That's
yeah.
my biggest concern.
Yeah, me either.
So I would not feel comfortable on, I mean, I totally support the concept, but the actual, what the recommendations are, I don't know because I haven't read them. Any other discussions?
I
Do
agree.
you want to table that then? Or?
Can that be circulated around and?
Yeah, it was circulated around after the last meeting, and there were some email discussions about it. So it's a voluntary recognition program, bronze, silver, and gold. We can, more time to review.
So
Move to postpone next meeting.
we have a move to postpone. I will make sure that we get it disseminated with Kate's help so everybody can read it. Is there any discussion on the tabling it?
No, I agree. I think we should table it because there's always unintended consequences of
Okay.
these.
Okay. All those in favor of tabling?
Good.
Any opposed? Okay, we'll put
I'm
it
not.
on the next agenda. And Sam, I'll work with you and Kate and make sure that we get it disseminated to the group so that we can have an educated last meeting.
Yeah, we need to
Educated decision.
make it a priority so we truly go through it and give you an answer.
Okay.
Yes.
So,
All right. Any other questions, comments? Okay.
Thank
Thank you.
Sam. So number 4, the consideration of endorsement of the position statement for transportation 724.017 is, who's the expert on this? I did not know how this got on our agenda.
which one is this?
This is number 4. This is the House Bill 434 relating to taking blood specimens from a vehicle operator for testing of alcohol or other intoxicating substances.
Yeah, actually, and for the audience, these are leftovers from when I was chair. So, actually, I think that came from
This was like a
Bill
long time ago,
and from
wasn't
you.
it?
Yes,
Yeah.
this is one of the things that is just carried over on our agenda, so we could talk about it if we wanted to.
It didn't require a vote or anything.
Yeah, I don't think it required a vote. We did look at some sample protocols, they weren't really ready for prime time. I would say if the committee wants to pursue this, I can resurrect it and send the stuff to you, or we can remove it from the agenda.
Did the bill pass?
Yes, sir.
Yes,
Yeah.
last session.
It's in rules.
It's in rules.
Yeah, I tried to pull it up, I just couldn't do it.
Okay,
It passed in the 83rd session.
so that's last time.
Last
Yes,
session.
the
2 years
last
ago.
one. And the, what the bill says is that paramedics or EMTIs can draw blood at the request of the police, but there has to be a protocol approved by the medical director for that service, and you're not required to do it. If the medical director doesn't want to do it, and authorize people to do it, they don't have to do it.
I know we did that, I think, for Pasadena, and the statement was added that we will do it, but if we get another call, a party one call, we're going to have to bow out, basically, and that allows us to have that flexibility.
Sure.
I think the intent was to provide on our website sample protocols.
Yes.
For other people in the state.
Okay.
The sample protocols we had were very much draft, and they weren't I didn't think appropriate to
Okay.
publish.
So I'll work with you, let's get those up, and then if we can get them next time and get them on the website.
If I
mean,
can
I
find
know
the one
we've,
we've used.
yeah,
I can find.
I know
I'll find it.
we've had some issues in southeast Texas where they've delayed transportation of patients wanting to draw blood. And so I don't know if other people are having the issue, or maybe it's just us, but we'll work on that. Okay, we'll bring that back next time.
And
Thanks.
from the state position, we say to the providers, just make sure if you decide you're not doing it, that you have that dialogue with the police officer long before you have that person sitting there in front of you where they demand that you draw blood from them.
So does 4 stay on the agenda? Dr.
Yes,
Beeson? Okay.
we'll bring some sample protocols next time.
Okay.
All right, session number 5, scene control when there are multiple EMS providers and the issue of patients being transported across state lines. I know that this had came up multiple times before. I've heard no discussions in other committees recently about it. This had to do with who owns the patient or who's responsible if an out-of-state air ambulance comes in and I'm transporting them in my ambulance from the airport to the hospital and something happens, who's responsible? And I don't know that anybody from the state ever gave an answer.
We did provide an answer to the air committee a couple meetings ago.
Yeah.
And the response was if there was an issue after the patient was delivered to the receiving facility, if you have a question, treat the patient the best you can, get them to a facility, then bring the issue to us, and we would project it to the other state. Our neighboring states will work with us in looking at this and making sure the right care was being given. Our biggest message to the air committee was let's not stop caring for that patient. Let's get the person cared for and transported on.
Okay. Any discussions or questions on number 5? I think we'll remove that one.
Yes.
Thank you. GETAC Medical Director's webpage. I looked at it. There's a lot of older stuff on there. Most of it's still applicable. I think one we'll talk about in a second with Dave in C-spine. Has everybody reviewed
I had
that?
one thing that I looked, and I think the way the psych patient thing was left, it looks like there was some concept of us doing some medical screening exam or medical clearance, and that seemed to be where we were hoping to go. I don't know that I would sign off on that because I don't think it can happen based on what the psych hospitals require, and we just don't have the lab equipment and never will, and we don't have a urine specimen and never will.
So there are some field clearance protocols I know that exist and are moving, but you're right, it is in cooperation with the psych facilities to deal with that medical screening.
I'm also uncomfortable with the concept that if we got them cleared, we would then transport them. But if they're suicidal or homicidal, I don't think it'll ever be our role to transport those patients.
Okay.
I just got through a lawsuit in which we lost a patient who jumped out of an ambulance, and I don't want to go through that again. And I think the issue is, I tell my guys, if you get to the hospital, they want to transfer from the hospital to another hospital or to a psych facility, but there's a guard in front of the room, that means you can't do it. Because if it required a guard at the hospital where we have plenty of security, I don't want that patient in the back of the ambulance with just one person to keep them from jumping. So I don't think we have the capacity to do what that patient needs if they required a guard at the hospital. That kind of language needs to be in there, I think, to guide.
So our recommendation was, it said determine if there are situations in which EMS would be able to perform clearance exams and transport. It doesn't say we have to do it.
No, no.
I have to do it all the time. I think it's flexible enough.
So I guess one
If
question
we're
I
looking
have
at the
is,
same document.
does every patient who's being considered for mental health transport need to have potentially fatal drug ingestions like aspirin and Tylenol ruled out before admission?
It's at the whim of the psych hospital.
I mean,
And that can change day to day. Blood alcohol has to be 80 today, next week it's 40, next
Yeah,
week it
I
has to
think
be.
that there are regional things. I mean, obviously, patients at risk, Dr. Bradley, need, but there are some that are just straight, have a history, want to go to the hospital, but we unfortunately take them to the ED today. So this goes to number 11, position statement. So can we get Bill and anybody else willing to work with Bill to take this document and update it and bring it to us next meeting?
I'll work with him because we're going through all that
Okay.
currently.
Jared, Bill, anybody else?
Kennedy.
Okay.
And this is the medical director's position statement on mental health emergencies.
Yes, and that's on our web
It's on the
page
web
currently.
page.
Yes. So if we can update that.
It's, yeah, it's called MD position mental health
Okay.
patients, I think. But it's in the list of all
Yes.
of our little position
Yeah,
statements.
well, it was approved back in
Yes.
2013.
Yes.
So
I
it-
also noticed I need to get the documentation on the thianosulfate, the thianosulfate, the cyanide stuff that Dr. Moore brought up last time. Put on there. It's not on there.
Okay.
I think we discussed it last
yeah.
time.
I think
Put
they
on
got
there.
approved to
Yeah, yeah.
It's
I think
actually-
to support the use of
It's
it.
on GTAC's agenda for tomorrow because it wasn't on the agenda for last time.
Oh, okay.
And I found that a lot of hospitals are having to stock that because they can't get the old kits.
Yes.
It's just not being sold.
Okay. Is there anything else people have seen or have they reviewed that to see that we need to add or remove or update from the medical director's website? No? Okay. All right. Number 7, consider recommendations and position statements for various situations during which EMS or air medical providers may be overused or inappropriately mandated for interfacility transports. What's the history on this? Dr. Greenberg, do you know how it ended up on here?
I'm thinking.
Okay. I'll tell you, this is a problem we have in the state. And I think a lot of it is probably within organizations that have air and ground and mandates. I'm unaware. I don't have any complaints that have been brought forth.
I think the issue, and I'm sorry, I'm searching my memory. I think the issue had to do with specific hospitals with air medical services who would refuse a transfer or say the only way that patient can come here is if we come and get them.
Okay.
We come and fly them, and the sending doc's going, they don't need to be flown. But I can't remember the specific decision. Sorry.
Okay.
My memory be fuzzy on it. But like you said, we do know that occurs, that people are somewhat coerced into using services they don't feel like they need.
So do we want to deal with activation, appropriate utilization, or is there enough information? Do we want to refer to the guidelines that exist from AMPA and ACEP and NMSP, or?
Again, I'm thinking back. I think another one was I think we were also talking about the hospitals that say, well, every transfer has to go by EMS. Even the guy with a finger laceration,
Sure.
whose wife is going to drive him.
Yeah,
And
'cause-
they're
yeah, that
being
seems to-
forced to take an ambulance.
It's like it's a misconception, certainly amongst rural physicians, that, oh, we're transferring you, you have to get in an ambulance.
Right.
Right.
We see that all over West Texas. People come in
Yeah.
always in an ambulance for something they did not need an ambulance for.
And then they don't have a ride back.
Right, and then we're the bad guys.
Right. And they get a big bill.
Yeah.
So we've certainly had those kind of complaints. So I'm dragging back. We probably do need to come up with something, again, to provide support to the EMS services and the medical directors, because the EMS services sometimes are coerced into taking them when they know they're not going to get paid. I think we do need a policy or a position statement on this, and we'll have to refer to EMTALA fairly specifically.
So do we do it by ourselves? Do we need to bring in EMS committee and others to talk about this issue?
Is it on it probably needs to go
Come on,
to
Eric.
council.
Spit it out. You're coughing.
Probably needs to go to council to see who to work on it, or we
Okay.
can work on it and send it to council.
I agree, Dr. Greenberg. This is a bigger, I mean, this at first doesn't seem like it's big an issue, but it is. I think it has to do with helicopters. I think it has to do with receiving centers leveraging the fact that they're going to receive the patient if they're not sending a helicopter. I think there's another component that is related to, does the patient have to come by ambulance, and they're forced to send by ambulance? The transferring facility as well may think they have to go by ambulance. That may be a relationship with the hospital and a private provider. There's another problem that is about blood and blood products, and does the nurse have to go? How do they get a patient who has blood products hanging? The EMTALA rules are pretty clear. I don't know how receiving hospitals keep saying this, but the transferring facility and the transferring physician specifically have the responsibility for arranging that transport, and that shouldn't be contingent. The acceptance of the patient should be about the capability and capacity of the facility, and can they take the patient. How they get there really is the transferring physician's responsibility, but we need to provide all of them guidelines. It's mushy enough where you have air medical, private providers, public providers, sending and receiving facilities, and guidance from you guys from what I would say is a disinterested third-party perspective maybe. The EMS Medical Directors Committee is ideally suited to handle, because really the linchpin in all this is transport by some air or ground method, and the sending receiving is confusing at best, and I think it would be wonderful.
So it's not on GTAC's agenda. Do we need to bring it forth? Is there a recommendation from this committee?
I think it's premature at this point.
I think we should write it and take it to GTAC. You could do it as part of your report for a future council agenda item, but we can go ahead and start working on that. I'm doing your report well, you know.
Okay, and I'm taking notes too.
Yeah, I got it.
Okay, we'll
Did
take
you
it
have a
forth to
bad
GTAC.
stroke?
Report from Trauma Systems Committee Registry. Kudos to the registry group. They've done great presentations. They're actually being able to now get data out. I know there's going to be a good presentation tomorrow at the council meeting. The sidebar discussions that I've had with the group is our data system, or our registry, is compliant with version 3. It is at NMSIS right now, being validated. I think April was the date potentially that we'll hear back it's good. We will be able to then start sending data to GTAC. There's also a discussion that I'll be reaching out to probably Jared or somebody, and the registry would like to find a closed somewhat environment where there's a good trauma hospital and preferably one primary EMS provider to see if they can experimentally, I guess is not the right word, but there's a way to match files up. And so they're to the point now they want to kind of test that. And so I'm going to be working with them to see if we
By
can.
match files, you mean the...
So what will happen apparently if the EMS run report puts the hospital's number in the report, they will be able to match the files up, theoretically.
Right.
But they're, I think, to the point where they would like to find a small test bed and see if that could work. And I know that was a concern of ours from this committee. It was a concern of the EMS committee that, you know, we're putting all this data in. We really would like to get outcomes data. And how do you merge those files? There has really never been a way, and now apparently there is potentially a way. So they've done a great job. And that's all I can say. They've done a great job. There's been a lot that's happened in the last year with the registry, and for those of us that have been putting data in for 20 years, there's actually data they can get back out, which is impressive. So,
Dr. Beeson, what kind of data can you get back out?
they had a report on. Oh well, come tomorrow. It'll be a great report. It is good, Colin.
Well,
You might answer the
so one of the key points from yesterday's discussion at the meeting was that when, in April or so, when the registry is finally NMSIS compliant, they'll be 3.3.4, and we'll be one of the first in the nation to be 3.3.4.
Yes.
So that's a pretty
So
noteworthy.
for those of us like
accomplishment.
myself who've been upset that, I sit on GETAC, or on NMSIS's Technical Advisory Council, and it always hurts me to see one of the only states that's not putting data in. But now there's actually been a benefit for us not putting data in, because we're actually going to be ahead of everybody else, because we're going to be on the new version, so.
Correct.
So I'd like to say that was strategically planned, but we'll just take it as it is, so. So Dave, epidemiological reports primarily, injury, age, there's been a lot of
Response times?
I'm sure that they could measure response times, because by God, that's the only thing we've seen to measure very
Yes.
good.
Yeah.
What it matters is another question, right? So, the nice thing once we get into NMSIS, NMSIS has a great available cube for online data to be able to search. So you'll be able to go to Texas and isolate all of Texas's data and run reports and things on it. So once we get to that point, there will be readily open, accessible public information that you'll be able to get off of the NMSIS cube. And I know that the registry folks, if there are specific things that you're wanting, you can email them and they can answer. Am I over speaking, Colin, or are they in the room?
Yeah, so if you go to the registry's webpage, there's public use data files for both hospital and EMS. And I believe you can choose from any of the selected variables there. So I think there's probably 150 each at least.
Actually, that's a good point. The next meeting, I'll have them come and talk about the reporting features. I mean, we've talked a lot about the progress, but I think to the point now we could probably have some how to use. How can you, as an end user, go in and look and see the data that exists?
Yeah, so I just went to the webpage here, and I believe it is public use here. So, for example, you open up EMS, and there are all these different variables. It will tell you if they're either available or not available. Cause of injury, etc.
And so then how do we run a report on that, Colin?
So it's to my understanding that you would contact Chris Drucker and his crew over at the trauma registry and basically formulate a research question that you want an answer to, and they can help you with all the different ways to use their data to answer that question.
Okay.
And it's just trauma now? Can you get anything other than trauma?
Trauma for now, yeah. Well, there are non-trauma transports in there too that are being recorded, although not as many as we think there actually are. So
All EMS PCR data
Yeah.
has to go into the
Yes.
registry, no matter if it's a trauma or cardiac or what it is. About 54% of the services are inputting right now. We're doing a big push on getting the rest of them in there. From the hospital side, it is just the trauma data, but we'll be able to match the two.
Okay. Any other questions? Thank you, Colin. So number 9, consider approval submission of GETAC talking points on position statement sample guidelines for field clearance, limited spinal motion restriction. Dave, I know it's been on here a while.
Yeah, last meeting brought this up, and I thought we're squared away. Is that
Okay.
fair?
Yeah, well,
So it's on the, we have the document, the ACEP document, I think, linked to
an AMSP. yeah.
NMSP and the ACS TAC, right?
Yeah, but it's two different things. One is we have endorsed that document. It should get endorsed by council tomorrow, but the offer was that we would provide sample protocols for
Okay.
clearance. Honestly, I think most of us have them anyway, but that would be another example of something we would post to our medical director page. You know, one is to say, hey, it's okay to do it. The other is to say, here, this is how you do it. So it's the sample protocol part, I think, that's pending.
So,
The kicker is,
just need to
could
email
each
them?
of us just pull one out and send it in?
Email them to
well,
you.
go ahead.
I would say email them to you.
Yeah, you can email them to me, and we'll bring them back to them.
Yeah.
Or how does everybody want to do this? Do we
Well-
want to put them on the website, or do we want them to come back and everybody review them? What do we want to do?
Well, this is where I think if we're just putting sample protocols on the website, I don't think we all have to review them.
We're just sending them
They're
to y'all, make sure
resources.
we put resource link. Just so you know, this will come up again. ACEP has just presented a, it's still in draft comment, but a position on this which goes well beyond what NMSP and ACS's paper, because that was some of our concerns that didn't go far enough. And so we may be talking about this again soon. I do know that we need to probably get some information somehow, and I don't know if it'd be through the racks or where, because I know that EMS agencies are probably a little farther ahead of this than most receiving facilities, and I know a lot of mostly ED nurses and others are complaining and getting upset because paramedics aren't bringing patients in on backboards. I don't know how we get that information out to the receiving facilities. I know it's beyond the purview of this.
I think it's just time. Just with time, it goes away and people don't realize it anymore.
It creates friction currently.
Right.
And time will.
I mean, we did it about 18 months ago. The first probably 6 months were painful. Now if somebody shows up on a board, it's, wait, why the heck are they on the board? All the nurses are, it's like flipped the other way now.
That's kind of the way we've noticed it. It just takes
Yeah,
education.
Every time we change something, you encounter that inertia.
You try to
It's just part of
educate
the nature of the beast.
The racks might be a way to educate facilities, though, because they have the relationship with all those facilities. And so if we were to present this, to the rack chairs committee meeting, that might be a way to disseminate.
Okay.
What is this? There's a size limitation for what can be put on the webpage, though, right?
Yes.
What's that?
I don't know.
Okay. Yeah, so you can't send
I
your
can find
entire
out.
protocol book.
No. But
But-
are you talking a single document or a total amount of size we have to use?
You're just talking one pages.
I'm
you
talking
can't
about
put a 20 meg file.
Yeah, I'm talking about the actual size
Okay.
of the file. So sure.
Yeah, please don't
Just
send
want
me
the
your
one
whole
page.
document of protocols. Just send me your protocol pertaining to spinal restriction or clearance or whatever you have. Thank you.
Dr. Beeson?
Yes.
Yeah, and I just need some guidance from this committee. Do we use the term spinal clearing or spinal assessment? And I always, over my career, I've heard both terms, and it seems like, to me, it would be a spinal assessment that did not need a backboard. I'm not sure we're actually clearing the spine in the field, and I just want to make sure I'm using the right terminology when I speak about this.
Usually it's spinal immobilization or protection or something like that, so you're not really clearing anything. You're just protecting what's hurting.
I agree with you. I mean, we don't.
So they're referred to as field clearance protocols. I get your point on the semantics of them.
Yeah. I mean, I think they apply once you clear, you don't go forward with stabilization. So, yeah, clearance is a word I would use.
Okay. I just want to make sure I'm using the same terminology.
No, I mean, all the data will show that there is a potential for injuries, but remember, we're looking for the significant injuries, and the whole question is, are we causing more harm than good? And it's very
I support the move 100%. It was truly the terminology, because we don't clear a broken leg. We don't put a splint on them because they don't have a broken leg. And we do an assessment. Yep, they need a broken leg. They don't need a splint on the leg. They don't need a splint on their arm, whatever the case may be, because during our assessment, we made a determination they didn't need it. And I just want to make sure that
you can use big words up in the Northeast and start talking about the square root of all word is the Greek meaning. But this is Texas, man. Start to slur stuff. Drew a little bit out of your mouth. Come on, you're in the South.
Yeah, the one I have is.
the question again. I promise.
You'll love this. The one I have is clinical clearance for spinal motion restriction. How's that?
I have a suggestion. I happen to have been at a couple conferences where Dr. Bledsoe gave his spiel on no backboards, and he calls it rule in backboards, not rule out.
Rule in, rule out.
Well, it's
Okay.
but it's no longer even backboards. It's
Right.
now we're just talking about collars.
That's right. So we'll get those sample protocols.
We're whittling away the.
Boards
Get 'em
are
up.
just to get them to the truck.
Yeah.
Number 10 is Dudley here. He's probably eating lunch while the rest of us wish we were eating lunch.
So I'm
because
heading out with some guys.
he
so-
talked forever. And no, that was Dudley. Consider municipal county letters for approval of EMS provider applicants as required by Health 77305. And I'm not going to read this entire thing, but you can see number 10 on there. Does anybody
I
No.
can comment. I'm not sure what the issue is. I can tell you that we've met with the League of Cities and the Texas County Association and given the NHTSA document that talks about how do you assess your EMS community needs and offer technical support. And as of today, we've received no request for anything. So this is, in Senate Bill 8, signed by the governor. If you're going to start a new service, you need a letter from the municipality authorizing you to provide that service, and it's based on four questions. Our recommendation has been to municipalities, if they call, you don't need to fix this. You give the 4 questions to the person trying to start the ambulance service and say, when you present before our committee, it's got to be done in a public hearing and all that kind of stuff, a public meeting. Answer the questions, and then the board makes a determination. So I'm not sure what the issue is here.
Okay, that's fine. I'll ask Dudley if he wants it on the agenda. If not,
Yeah, we've had a lot of discussions with a couple cities and helped them out, but I'm not sure there's more work to
Okay.
be done.
Number 11, we talked about. We're going to be working on that with a bunch of us. Number 12, Kate, I'm sorry, Dr. Remick, the presentation of pediatric transport.
Sure. Are we able to pull up that document? That was.
Where is it?
It's in guidebook.
I can put it up. I can do this. Do we- The pediatric.
Oh, okay. Sure. Yes. Might have looked at that either.
Just so we can walk through this, since that's the purpose here. The Pediatric Committee developed a work group to develop pediatric interfacility transfer guidelines that could be used for the state. The purpose of this is knowing that trauma facilities are required to have trauma centers are required to have interfacility transfer guidelines in place, and how we can make this inclusive for pediatric critical illness as well. And it's really just intended to be a template that facilities can adopt. So this is by no means specific recommendations that have to be utilized. It's just a template. And we realize that there are varying resources of different centers, and that what approaches work for one hospital may not work for another facility. And all of that is mentioned in the introduction. And if you could just scroll down to the considerations, you'll see here that it says only the critically injured child and or child whose level of care exceeds the local area capability should be transferred to a level 2 or level 1 pediatric trauma center. And it is also accepted that, whoops.
Sorry. There we go.
Oh, back up a little bit. Right there. It's also accepted that some level 3 trauma patients may be admitted to an ICU for close observation, but if the patient begins to require ongoing ICU management, that they should be transferred to an appropriate level 1 or level 2 trauma center with the capability to care for a critically injured child. As it goes on, really in the 3rd paragraph down that begins with "because the state of Texas," says that we encourage hospitals to align themselves with a facility that has the capacity to manage pediatric critical care and pediatric trauma. But it's not intended to mandate transfer outside of a region, just to heighten awareness of the need for pediatric critical care and transport and pediatric critical care and trauma services. It highlights that GETAC recognizes a pediatric patient as age 14 years and under. That's in the next paragraph. And even though some early teenagers may look as though they are a small adult, it's important to be cautious with the practice of treating them as such, just because of special needs, both physical and emotional. And then it goes through specific considerations for pediatric trauma transfer. And again, this is just a template for considerations, but not specifics. Specifically for trauma transfer, the recommendations are broken down by physiologic, anatomic, and other criteria. The reason for this is based on what we see similar to CDC field triage guidelines and what might be available. The physiologic criteria relate to neurostatus, respiratory status, shock, requirements for blood transfusion or invasive monitoring. And then for anatomic criteria, we're talking about deep penetrating wounds, multiple fractures of long bones, fractures of the axial skeleton, spinal cord injuries, traumatic amputation, head injuries that are significant in that you have CSF leaks, open head injuries, depressed skull fractures, a decreased level of consciousness, intracranial hemorrhage, penetrating wounds to the shirt and shorts area, pelvic fractures, and significant blunt injury to the chest, abdomen, or neck. And then there are other criteria regarding child maltreatment that might be considered for transfer to a different facility that may have capabilities to manage pediatric patients that are suspected to have injuries due to non-accidental trauma. If you move down, there are then recommendations for burn transfer guidelines. So these are American Burn Association transfer criteria that are put in there. So those recommendations are there. And then number 10, specifically burns in children should be transferred to a burn center verified to treat children. In the absence of regional pediatric burn center, an adult burn center may serve as a second option for the management of pediatric burns, and just as a recommendation. And then the last area of recommendations are for non-trauma transfer, so that's the next page. Colin, if you could just scroll down one more. Again, broken down by physiologic and other criteria. So this would be for just critical illness, not injury, and again refers to neurologic status, respiratory status, cardiac arrhythmias, arrest, shock, etc., and those who require invasive monitoring. After that, there are some recommendations regarding how you might consider transport, what you might actually use for a transport team. And in that first paragraph, the recommendation is that there be a process for initiating that transfer in terms of gathering required paperwork, as well as a process for informing the family, giving them maps to the receiving institution, so basically having interfacility transfer guidelines in place for how that would look. And then next down, method, transport by private vehicle is not encouraged with sick or injured children. Only in that you're talking about transferring to higher level facilities, so these are critically ill or injured children. And then as you move further down to, considerations regarding what equipment is available and what staffing might be available. So it's important to highlight that there are recommendations for communicating between the referring and receiving facilities and making sure that the workup that's completed is required or not required prior to transport. There's also recommendations on back transfer, so if a critical illness or injury has been stabilized and there are the resources available within a particular region, that child may then be transferred back to the original facility. And then regarding specific transport team configuration, with attention to specific patient factors, choosing a method. And it breaks it down by those patients that are stable with no risk for deterioration and recommendations for basic. I'm sorry, if you could scroll down one more page.
Back.
No, further down.
Okay.
Sorry. So stable, no risk for deterioration, stable with low or medium risk for deterioration, and recommendations for advanced life support based on equipment available, and then stable with high risk of deterioration or a patient who's otherwise unstable, the recommendation for pediatric transport teams if they're available. And again, these are just a template for what interfacility transfer guidelines might look like. And then finally at the end is a list of children's hospitals in the state of Texas, just so that those are available as resources should a hospital want to have those available to know where the nearest children's hospital is for their region.
So this would not include recommendations for, say the kid was intubated, what sort of a ventilator you would recommend?
It doesn't get that specific, no. It just has recommendations on if a child is intubated, what mode of transport you might choose based on that.
Okay, air versus ground or whatever.
Correct.
Okay. Sounds good.
And of course, it's all going to depend on the region and what transport times are and inclement weather and geographic challenges and so on. It's really just a template because we know that many facilities do not have interfacility guidelines in place for pediatric illness and injury. So it's just to help facilities develop their own set of guidelines.
Yeah, I know some burn centers have certain IV requirements or certain, they want to use, lactated ringers as opposed to normal saline or whatever.
No, it doesn't get into any specifics about management at all. It's just recommendations for transport. And it's really, it's going to be highly variable based on the region and the facility. So it's just a template.
What's the source of the hospitals listed on the last page? Where does that come from?
That's a great question. It's supposed to be all of the children's hospitals in the state of Texas. I would have to ask Sally Snow where she came up with that, but I know that there is one hospital that is not listed here, and that's Edinburgh Children's Hospital.
Thanks. I can think of another two.
Oh, okay. Right.
Well, yeah, does that include the facilities that are like level 1, level 2 children's trauma facilities, but not a children's hospital?
I think she just put, or the work group just put the children's hospitals on here, and they're not necessarily the trauma centers. I think she was just putting them there for knowing where the resources might be for pediatric critical care centers, but that could easily.
Yeah, I guess, I'd make it clear that that's not an all-inclusive list, because there's certainly very high-functioning pediatric centers that are part of a much larger complex.
Mm-hmm.
But it's not a children's hospital.
Okay, so the recommendation would be to make sure that all pediatric critical care centers are listed here and not just the children's hospital.
And if they're designated, put that on there, what level they're designated for.
And it may be too complicated to get all of them, but, somehow let people know there's more than that available. So maybe that's a sample list, or maybe those are the centers that participated in this document.
Or maybe by RAC.
No, I don't. These centers didn't participate in the document, so I think it was intended to be an all-inclusive list of the children's hospitals in the state of Texas, but clearly there were some that were missed.
I think initially the list was designated pediatric centers, initially for trauma, and then others that were in pursuit of trauma designation. So if they aren't designated as a pediatric center, they're probably not on this list. But I agree with Dr. Greenberg, it should be entities that have the ability to care for critically ill children as well. So that is the list that we started with. So that's all I'm agreeing with.
Oh, great.
So, Kate, the only two things as I read through it that I would question is the private vehicle. It says no sick or injured kids, but I, especially as we talk about who needs an ambulance and who doesn't, I think there's a lot of kids that are going for specialty care, ortho, or other things that don't particularly need an ambulance, and I think that we may be closing the door on that discussion. And the other thing is, you said it, but it's not typed, the specialty teams, if available. It says encouraged, but I think the if available would be added, because I think that if somebody has an outcome and the specialty teams were not available and it says, well, here are these recommendations, they're encouraged, why didn't you use a specialty team?
Sure. Sure. So I can make sure
Then there's the bad outcomes because you waited for the specialty team for something the specialty team really couldn't do anything about, and they needed to be to the surgeon.
Sure,
Yes.
absolutely. So just to be clear, would you be comfortable with transport by private vehicle is not encouraged for critically ill
Yes.
or injured children? Okay.
Just kind of it's a shame you have to even say that, but yeah.
Thank you.
All right, this will be discussed tomorrow also at GETAC. It's under discussion, so it's not up for any type of vote tomorrow at GETAC. So is there anything we want to go forward or recommendations coming to this committee?
Yeah, I would just recommend dividing it up by RAC so that each RAC knows what's available to them, and then maybe how many miles from certain town.
Okay.
I mean, I don't know, maybe miles is crazy, but by RAC, what are you available?
By RAC or by trauma designation?
By trauma designation and by RAC.
At the top, and then, so in the RAC, if you're looking at trauma patients, by RAC and what's
Right.
the highest level designated trauma facility for children.
Okay. Thanks, Kate.
Thank you.
Thank you.
Number 13 is work group consideration of the community paramedic clinical didactic. Education has worked a lot on this. Dr. Malone, Jarvis, and myself have not. We need to get with them and find out what's going on with this, and I'll report next time. Number 14, recommendations regarding Narcan administration, persons by not certified licensed EMS. Dr. Malone wanted this added. She unfortunately can't be here. I'm sure many of you are aware there is a bill that pertains to Narcan, and naloxone technically, but it has to do with administration without a prescription. It really doesn't. When I read it, Joe, it doesn't have any pertaining to EMS. It was sent to me to review. It's more for the layperson who, if I have a prescription for naloxone and I administer it to him, it sounds like it almost gives me immunity, although it wasn't prescribed to him. That's the way I read it. Is that true?
I have
or?
not read the bill.
Okay. Anybody know about it?
I haven't read it.
I know this is a hot topic now that there's an auto injector for naloxone. Everybody in the world wants to start carrying it, so should have bought stock in that company. Number 15, work group recommendations on GAP. This is going to be with Dr. Peirce, and I don't know, Bobby, did this go anywhere? They met?
No.
Nope. Okay.
Not that I know of, and I don't know if it's on GETAC.
It's actually on GETAC tomorrow too, so
Okay.
I'll have a discussion on it tomorrow. Number 16, I added recognition of interstate the compact. So I was the unofficial representative of Texas at the NASIMSO medical directors meeting last month in New Orleans. There was discussion on this. It's called Replica. It's an EMS interstate compact. So nurses have a compact license that's accepted in many different states where you can move and easily get your license. Physicians, we actually have legislation that's introduced in this session to create a physician interstate compact. This replica is being discussed by many states. Joe was actually part of the writing group when he was up in the Northeast. There is currently no bill or legislation introduced in Texas. The concern that I have with this is there's many reasons why this is a good thing. My concern, and I don't know how to overcome this, that if Dishes drives this will be a multi-year process to get through legislation on their standpoint. The way the rules, in a sense, the way it works right now, once the first 10 states adopt the compact, those 10 states will sit at the table and write the rules on the compact. If you come in after that, you sit against the wall. And if we don't get something moving here in Texas within the next month, then it won't be until another 2 years when we have another legislative session and attempt to get this through.
Wouldn't that be something that TTAP might be able to push for us?
That's a good point. I don't know.
Our RACs
I'm
pay
still learning about TTAF.
Pay a lot for TTAP's. They're able to lobby as opposed to the state.
I'll ask.
So they might be able
I think
to do
Dion
that.
or Diane or whatever.
Diane,
her name is,
yeah.
Diane about that. So, if anything, if folks can read the compact and if you have your personal thoughts on it, I think it's an important thing for us in Texas. And that's all I got to say about that. Has anybody read through it or have any questions about it? There's really no action to be taken on it. So, Bobby, update us on the strategic plan for EMS and systems trauma.
Yeah, the recommendations from this committee went forward to the council at the last meeting. Tomorrow at the council, Dr. Eastridge has taken all of the committee's recommendations and put them together into the overall document, and there'll be a presentation tomorrow. I'm not sure how robust it's going to be tomorrow because I think tomorrow we're going to decide that we need more time to really go through that document, and it's a large document with lots of little things in it that could be big things and large things in it, which are large. So it is proceeding to by the timeline that has been set, and they'll have more tomorrow. And like I said, I wouldn't be at all surprised. I don't want to speak for Vance Riley, but I wouldn't be surprised if he doesn't want to have a separate meeting.
It's going to have to be because there's no draft in the documents. I don't know.
Right.
There's the existing strategic plan from 2002.
Right.
But there's no draft document.
Right. The draft document will be available tomorrow.
Will be available.
And looked at by the council.
Okay.
So.
And number 18, identify the work list accomplishments of this committee. Dr. Greenberg, got it up there?
Yeah, so, and I worked long and hard on this, or I did it earlier in my hotel room. Actually, getting the information together was quite a challenge, and I couldn't find anything prior to 2006 because we don't have anything on our website. I wasn't keeping minutes before then. I don't know that Dr. Ellerby has much either.
Has it been 9 years since we fought over what
Yes,
patient?
over what I actually found it. I found that if you want to see it, what a patient is. I think we've lost a great deal of the work we did.
Bigger than it used to be,
Yeah,
whatever it is.
yeah, whatever. Yeah, the patients are larger. I think we've lost a great deal of the early work just because it was all done on paper, and I have no idea where it is, and I doubt that Dr. Ellerby has it. And Steve, were you the first chair of this committee, or was
Ed was, wasn't
it? So Ed was, and then yeah. So we're supposed to do this from the from when the committee started, but I don't think we can. I don't think we have those documents available to us. Because 2006 was the earliest I could find from my notes and stacks of stuff.
We can blame it on Ed, that's nice.
We can blame it. He's not here.
He's not here.
Yeah, he's not here.
Okay.
So these were the position statements that I could find. I think what is a patient was the first one we did. That took several meetings, years,
I'm
long
sad I
time.
missed it.
Yeah. It was way more complicated than you thought. And then you can see the other position statements we have. And then if you scroll down, these were the things that I found that I thought some of the accomplishments we had done. And after you read that, if you scroll back up to the top in a minute, not now, I'd like y'all to read the first sentence I put up there and see what we want to do with this, if it's worthy of forwarding to the council.
Colin, can you pop back to the top, please, sir? Sure. That's a big word.
I like that.
I like it.
Is it good?
How do you document all the time we spend on Plan A, Project
Oh.
Alpha? what was it?
Project Alpha.
Project
There you
Alpha.
go.
Oh, that's why we have no documents.
That's right. 'Cause we all
They had to be
found out.
burned at midnight.
Right, is there anything these people need to add? Is there a motion that we do something with this to GETAC? Or we need a motion, Bobby?
This is supposed to be forwarded to the council. It was something that Chief Riley wanted from
Okay.
every committee.
So we need a motion to.
Motion to forward to the council.
Motion, second. Any discussion? All those in favor?
Aye.
Any opposed? Thank you. Okay. Any public comments in the last 6 minutes and
Can
23
I
seconds?
add one question?
Yes, sir?
Every time I come, I just print out the list of all the medical directors on the medical director committee, and I realize there are errors. How do we get that changed? It's been the same way for every time I do it.
Website.
For example, I'm no
Update.
longer chief of staff of
Is it
anything,
him?
so I want to get that off.
Send me the corrections. I'll take care of it. Yeah.
Okay.
Can I just, yeah. okay,
Yes, sir.
I'll give them to you right now.
Yeah, somebody asked me about the GTAC council website. It wasn't up to date, so I wasn't blaming anybody.
Oh, I know.
Public discussions. Joe, you said, come on up, Eric. Joe, you said something earlier that intrigued me. So we have the ability to identify all medical directors now in Texas to communicate with them? Because in the past, that had come up years in the past, and there was apparently no way to identify all the medical directors.
Yeah, we can identify, we may not have a. Yes, we can identify all the medical directors with our agencies.
Okay.
As long as the ambulance services reported the change to us, we have the current information.
Okay.
That's a responsibility that they're supposed to tell us.
Okay.
But what about with license renewal, though? We have to check the yes or no.
Well, that TMB will have it when people
I guess
renew.
we're not all the way through.
If they click
If they
that
click
they're
it.
a medical director, and there's no cross-reference between.
TMB gets a report dumped from our database of
Okay.
who we show the medical director is on a routine basis, and they're updating that on there. So
Okay.
when you pull down your list on your TMB application, you should just be able to select your ambulance services.
Along those lines, didn't TMLT give blanket EMS medical director coverage to all their insured?
If they did, that's new, because in the past TMLT did not cover delegated practice.
They will now. I don't know if it's.
They will. In
blanket
fact,
or whether have to ask for
you
it.
had to opt out of it. This was my question.
I think it's entirely new, as of October,
Okay.
that it was available. I don't know whether you have to opt in.
The way I read it was you have to opt out or it was automatic.
Okay, I'll ask. I'll find out. Yes, Mr. Eckler.
So I wanted to alert you guys.
I'm going to send, by the way, this list. Y'all make corrections while we're talking. I'm sorry.
That's okay. Senate Bill 538, Senator Schwartner has submitted a Senate Bill 538, which addresses infectious disease emergencies. It's a quick 26 pages, but maybe 26 pages you want to read, among other things. It has some really good pieces to it, mainly about sharing of information if there are people under control orders with first responders, so that you have an address and if they could be exposed if they are arriving, and maybe weren't completely PPE'd up, they would, but that information could be shared. There's some other parts that I would ask you to look at that basically put the Commissioner of Health as the in charge of all aspects of public health, acute health care, emergency management, and public safety for the operation, which means you would lose any capability to manage your own EMS systems. That would be under the control. If that state of emergency were declared, your system would be at the behest of the Commissioner of Health. So, that's a change. It's kind of a radical change in our state's process. Certainly, we want to make sure we're in lockstep in those kinds of crisis moments with infectious disease. At the same time, we need to make sure we're thinking all the way through the potential of one Supreme Allied Commander approach. I think that bears some discussion.
Dr. Lakey, the former Commissioner of Health, was an infectious disease expert. How about the new guy? Does he know and understand?
I think one of the challenges with any of these kinds of rules is you need to have some kind of order, you need to have some kind of process, but we are a home rule state. I mean, that's fact. This would change some of that in those infectious disease crises. Having the emergency management being managed by the Commissioner of Health as opposed to the emergency management, that's county judges, that's mayors, that's emergency management coordinators and police chiefs and fire chiefs, all really it's a pretty radical change to the way we do any other business. And consultation and working together, I think, is a good idea. I just would encourage you guys to read it for yourselves, take a look at it, and speak to your representatives if you have any thoughts on it.
Thanks, Jack.
Dr. Beeson, I just wanted to clarify that we don't have all their emails, but we can do a project list, a mailing list.
Okay. No, I was just glad to hear, because I know that came up in the past when we talked about trying to find those living medical directors. We could find the dead ones.
Our data is only good as what they've told us has changed.
Okay. And that's not something Board of Medical Examiners can provide?
They're that probably soon.
They're probably going to be better. I'll ask. I'll find out, because that would help us be able to reach out.
We've been asking for a simple check box that says EMS Medical Director.
We have it now.
It is there now.
But I mean, that took like 20
Yes,
years.
it took forever.
I've been doing this a while.
Well, and when you check that, you then have to pick your service.
Yes.
And, yeah.
Because it limits the number of services. So. Okay.
All TMLT policies renewing on or after May 1st include coverage for administrative activities as medical director.
Wow.
Administrative.
That'd be like a department director, I think, though.
Yes.
Yeah.
Not an EMS.
As opposed to hands-on practice. No, it's EMS medical director.
We'll clarify that.
Yeah.
I clarified it with TMLT.
Okay.
It is EMS medical direction. Cool. You may contact TMLT to decline this coverage. Currently it's blank.
Does this mean we only have 15 seconds?
We have a motion to...
Dr. Beeson, I just want to remind all the
We have
doctors that online medical command course is still free until August. So about 150 of you taking advantage of that. The rest of you need to get it. So if you haven't taken it, it's still
That's
free.
why I was glad to hear there's something that we can try to send out and communicate to people.
Yep, and there is a notice out on the front table if you don't know how to get into it.
Second.
Move second. Any
Do we
opposed
have
to the
websites
motion?
out there?
Yes.
Okay.
We're done. Thank you.
Thank you.
Look, and 0.9 seconds left.
No,